Good afternoon,
Hello, how are you?
Rob.
Yeah,
Love the picture. We must be bow tie friends.
yes.
I saw you pop up with that, and I'm like, yes, someone that enjoys a bow tie.
Is
And
it
then I
just
realized
us?
there's we're expecting about 10 more.
Okay, great.
So they may just trickle in, but I want to be cognizant of everybody's time. So I want to get started here very quickly, and obviously we can add this transcript and video over to the folks that do join us today. So I think we're right at 12:30. So let me go ahead and begin by saying that I appreciate everybody joining us today for Freedom Healthworks Lunch and Learn. What my goal is today is really to be informative in this lunch and learn and to help address questions that I've answered over the course of the last 6 months to a year in the practice that we do for DPC startups, and try to address some of the thoughts and concerns and try to put those together in a format that will hopefully make sense and really go down the the path of where you might be. And everybody is going to be probably in a different space. I don't know where everybody is in their DPC journey. Some might have a thriving practice currently. Some might be starting a practice. Some might be thinking about starting a practice, or in the middle of startup. So I want to try to address a lot of different things and a lot of different questions that have come up. So I do appreciate everybody joining us today. I will go off video here real quickly, and just a little bit about myself for those who may not know. Again, Brian Wikle with Freedom Healthworks. I have been in the healthcare space for about 32 years or so, dating myself. And in that time, I have really crossed over many different verticals of work within the healthcare space with healthcare organizations around the country. I've worked with payers. I've worked in the Medicaid space. I've worked with the Department of Health in many states around the country. And I've also interfaced with CMS, ONC, and a number of different policy and procedure uh, healthcare issues over my tenure. So I want to just give you a little bit of background on myself. So let's do this and go right into it. And let me share my screen. And then, Rob, if you could give me the thumbs up that you can see that.
Looks good.
Okay, fantastic. Well, again, today there's a number of things I wanted to do, and that's define what DPC is. I want to talk about a hybrid Medicare model because we're asked many times, where does Medicare come in? And I have a lot of Medicare patients, so how do I address that? And then overall, where do the patients come in from a standpoint? If I'm opening up a DPC, how do I address my current patients, or how does that patient enrollment happen, and what does that look like? And then finally, what does a solo physician transition look like? So we're not going to solve all the things of DPC today, but I thought if anything else, I wanted to be informative, give you some ideas that might create conversation, depending on where you are in your journey. So again, uh, breaking it out with direct primary care versus concierge, which comes up in conversations, DPC and Medicare, how to operate a DPC while still having that foot in the Medicare space, and what are the compliance guardrails that we need to understand and really take into consideration. And then also, how does one physician really um, open up a DCP practice within a group practice? How does that look from an impact of liability, and why a separate TIN would be necessary in a hybrid type location? And then understanding the four pillars of the system of how to run a day-by-day DPC practice. And then obviously, we're always here to help support and some of the programs that we have for partnering with physicians that are going into the DPC world. So let's just start out with the definition. And again, I might be preaching to the choir here a little bit, but it's DPC is a membership-based model that allows patients to participate for a flat monthly fee for comprehensive care, and you're bypassing the insurance that normally would happen in today's healthcare organizations. Now, the difference between a concierge and a DPC is the concierge medicine kind of layers a membership fee on top of the insurance billing. So you still have that component of insurance billing in there, where DPC is just replaces the third-party payment relationship for primary care entirely. And basically, the patient pays the practice a flat monthly fee. You have a defined scope of primary care services. You don't have any claims, no copays, no coding for covered visits, and no payer interference in the treatment plan. And in my conversation with physicians looking to go this route, that is music to everybody's ears, because again, as everybody knows, the insurance aspect and having to deal with that, and the cost net of billing and for fees is extremely cumbersome, difficult, and unfortunately, in today's world, the physician is being shorted. I think for care and the services and the knowledge and expertise that the physicians bring to this to the healthcare community today. So the difference, again, and we've talked about this earlier, but the difference of why somebody would go a DPC route is because they got into being a physician because they want to take care of patients. They want to take care of people, and they want to spend time and get to understand them, and really the whole aspect of care coordination and understanding the patients and how to see direct results in the care. Well, the only way you can do that is that you actually have to have the ability to spend longer visits with that person. You have to be able to create a relationship with that person. And if you're having patient portals of 2,000 or more, it's a little hard to do that. So on average, we see around 450 to 500 to 600, depending on everybody's preferences and size of DPC practices they want to build. But with that, it also, from a patient perspective, it offers potential next day care, which obviously is not happening in today's society in the healthcare space. It also offers potential to direct messaging, and you can, as a practicing physician within a DPC, can put limits or restrictions on the type of messaging, but it is available, and a lot of physicians take that opportunity to utilize direct messaging. There's transparent pricing, which we don't have today, even though we're supposed to, and there's no payer interference in the treatment plan. So a lot of pluses on both sides, from a patient perspective and a physician perspective. So again, it's built for physicians who want to just practice medicine again. And we don't have to deal with any prior auths or denials, and we don't have to deal with any declining margins. And you can pretty much put yourself in a situation to replace that income and build that practice as big as you want to build it. And your quality of life comes back. The opportunity to spend time with patients increases. The overall quality of care increases. And there is everybody kind of wonders, is there an opportunity for a win-win in these types of scenarios? And absolutely. And we've seen this over the last 10 plus years that we've been supporting physicians going into a DPC practice, that the win is for the physician and the win is for the patient as well. So one of the other questions that comes up Pretty much right from the get-go, and it depends on where the physician is currently practicing. Um, Rural communities, a little bit more, I would say, just from my experience, compared to big city areas in regards to the Medicare population. But you can exist and coexist. And so, what I tell people is that yes, you can be a DPC practice and you can offer Medicare. They can coexist together. So that is a big plus. However, there's caveats, and you have to understand that there is compliance issues with Medicare while operating a DPC practice. And so what I did is I kind of broke this out into what it looks like from a hybrid perspective. If you carve out a portion of your practice for your Medicare patients, and typically when a physician is leaving a healthcare system or an organization, and they have an understanding of the current existing patient population that they have, they pretty much know obviously the certain percentages of what those would be on the Medicare side compared uh, to that would not be Medicare. So they can remain enrolled, but the structures is a little bit differently because see you're offering a membership fee, and those so when the DPC is offering a membership fee, it only covers services Medicare does not pay, and it requires this is where it requires really careful level service documentation for the patient agreement. So when you come up, and this is something we do as well, but when you come up with those patient agreements, you have to specifically say what the agreement states from a service perspective, because again, it has to be outside of Medicare. So what that usually shows is that when you have additional services that are outside, you need to list those services, because again, full transparency, and that's the thing I like about the DPC model, is because it offers full transparency into pricing and services and what it does have. Now, you also have to, if you're going to opt out, which here's where we see a lot of the paths going for practices that are get up and that up or running. And I would say on average, they're probably into it about a year and a half or so, maybe going into that second year of practice, where because you're offering the membership fees, and you talk about what's covered, what's not covered, and what Medicare does not pay. A lot of times it just gets simpler for them to say, you know what, my patient portal is growing, my marketing is working, my word of mouth, other people are talking, my website's driving additional support into my practice, the community I'm getting a lot of community support. I think I'm going to get in a situation where I can kind of opt out of Medicare and no longer accept that. And so that's typically what we see. Now, again, we won't go in and discourage anybody if they want to have one foot in and one foot out. But I think the physician learns over, again, about a year and a half to 2 years, that they'll probably just go ahead and reduce the Medicare patients um, over a length of time. And then obviously when you do that, you have to file a formal opt-out affidavit. And when you enter into private contracts with Medicare eligible patients, you have to have a clean separation. And we feel that's pretty much the cleanest separation you can possibly have. And then obviously you won't have any reimbursements for any services during that opt-out period. So there are ways to do it. And again, I think the takeaway from this particular slide and conversation is you can do it. You can get consultation through us. We can help work the contracting aspect of it if need be. But again, there's very specific things that need to be said, but we can service both worlds. So from and a little bit deeper into the compliance issues. So when I talk about the guardrails, obviously there's no double billing. That's kind of a given. But the membership fees must never cover anything billed to Medicare for that same patient encounter. And the document covered versus non-covered, again, has to be aligned with coding and what is billed with Medicare that is billed. And then again, what I said earlier about the patient agreements has to be written membership contracts that disclose what is and isn't covered with explicit Medicare languages. And again, we already just talked about the opt out. And every state's a little bit different. Most states have an explicit DPC status that exempt DPCs from insurance regulation. But we can also consult your state and find that out for you if that's a service that you need or want us to make a phone call on your behalf. So that's easily done. But I wanted to give you the background and the context of if you're going down this path, it is viable. It is something that a lot of folks do in the interim, especially in the interim. But there are guardrails that we have to be aware of, and if you are, then usually there's absolutely no issues, no problem, and you're serving your patients to the best of your ability, and they're getting taken care of the way they need to be taken care of as well, both from a Medicare perspective and also a physician perspective. So, what does a solo transition look like for an initial practice? Well, here is one thing, and I've seen this happen a couple different ways. So you have to kind of plan your exit strategy, as it were, in your existing space. And I've seen folks that physicians that are really, really excited about jumping into DPC, and so excited that they're having conversations internally with some folks, and some of those folks might not necessarily like the aspect of them moving to a DPC, because I think there's fear of patient stealing. And I think that's probably where a lot of it comes from. And I actually had a gentleman that was a longtime practicing physician in the state of Tennessee, and was vocally stating that I'm not going to renew my contract in September. And one question came up, and why wouldn't you renew your contract in September? Well, I'm going to a DPC route. And of course, that conversation led, well, instead of leaving in September, why don't you leave next week? And obviously that was kind of a monkey wrench to him. So that is kind of a lesson learned, that you fly under the radar. We will help you if needed to secure that exit, and understand that you can practice consistently in what you're doing today, but also starting to dip that toe into the DPC world and be able to do a little bit of both until that fully exit strategy happens. But there are such things as non-competes, obviously, as you know, and patient notification rights as well. And when you're forming your new entity, why would you need a separate TIN, for example? Well, you want to establish your own LLC or PLLC. And you don't want to get into a part of mixing non-participating cash pay practices under the same TIN. So if you're looking to say, hey, there's a group of doctors that I'm friends with that are in my community, and they have a practice, but I want to do a DPC within their practice. We always tell people, and it's probably not the right term to use, but think of it as you have 5 physicians practicing in a location, and one's a DPC. And so if you use the term moonlighting per se, then if physician wants location 1 to continue accepting insurance, and then you have location 2 under the group to operate as a DPC, we strongly recommend a separate legal entity for the TIN for that DPC location. And really, the reasons behind that get into Medicare and payer clarity. And if you're mixing non-participating cash pay practices under the same TIN as an insurance billing practice, it really creates a compliance risk around the assignment, the balanced billing rules, and really for those Medicare patients, the private contracting and the opt-out rules. So we just feel that to be safe and to play it straight and be fully compliant and not get too close to any gray areas. We just said a separate TIN cleanly isolates the DPC entity from those obligations. So we just feel that's just the best way to go. And again, when you're getting to the point where you're ready to communicate to your panel, obviously within the bounds of your group agreement, the DPC model allows sustainable access and again transparency in pricing, so they understand what they're looking at. If they're like, I want to follow you, I want to go where you go, so what kind of practice are you setting up? You're able to have those fully transparent discussions and help that patient understand exactly what practices, what services you're going to be offering, and the ability to really care for that individual. And again, it's going to launch a foundational membership base where most physicians break even, anywhere between 150 to 200 for active members. When we talk about that, and again, it varies from if you're in Tupelo, Mississippi, or if you're just outside of DC and say Arlington, Virginia. It varies with the city and the geographic location. And so one thing that we do to support folks is we do a complete deep dive socioeconomic background on the area that you're looking to get into, because one of the things that you need to really help understand is, what do I charge? What's a fair market value? So you don't want to leave money on the table for services and what you're doing for the patient, and you want to get paid for the value, but at the same time, you don't want to overprice yourself into the market as well and what the market will bear. So we help do that socioeconomic, and we try to figure out exactly where that level pricing is going to come in. That's feasible, but it also at the same time drives net new revenue to you. And again, it's going to vary. And I mentioned 450 to 600, but it all depends on what the physician wants to have, what's the income level they need to replace, and what city they're in. So, how does a patient panel flow, and what are the patient responsibilities, for example? So, and again, these are conversations that you're having and helping them understand. So, typically, what we see, and again, it's going to vary, but this is on average of what we see, that you're going to get about 8 to 15% of existing panel converting in the first 12 months when physicians are actively communicating the change. Now, that's just you actively communicating. That's nobody else actively communicating on your behalf, which is obviously something we do. But if you're just doing it on your own, this is typically what you can see. And it's going to grow as word of mouth builds, and it's going to get to that next level, double digit percentages within year 2. But conversion is driven less by demographics than by how clearly you're able to articulate the value in the practice and the prices. And again, I think the best way is to help them understand the impact of what enrollment looks like, and the impact of what DPC brings to them. Brings them flexibility, brings them the ability to spend more time with a physician, better access, quicker access, no surprises. You understand what services are there on a monthly basis and what the annual fee is. And you're not looking at, which most people do that are under an insurance-based plan with their employer, what have you. Everybody pretty much knows that the company that they work for is probably going to change insurance companies every single year because they're trying to buy and find different ways of the company saving money. But at the same time, that changes the dynamics and the metrics for the patient themselves as well. So as an employee, those fees are changing constantly year after year after year, where you're able to bring in, flat fees, transparent cost. And again, I'm not saying they don't increase a little bit over the course of time, but they they are nothing near of what you would find in an insurance-based benefit program through an employer. And in addition to the patients understanding the value of what you're doing, you're also being able to bring what we call Dose Direct, which is our vaccine program underneath Freedom Healthworks. But you're able to bring labs and imaging options to them, and again, you're going to be able to connect to a local hospital for cash pay rates with outpatient imaging departments. So there's additional services above and beyond just coming in and having services. So you're going to have a lot of tertiary type of benefits that you're going to be able to service the patient. And the patient responsibilities under DPC is very actually very simple. They have to they've got the membership fee and they've got the monthly fee that they would pay to you, but anything outside of a defined primary care scope is really up to them. So we've obviously there's catastrophic type programs or insurance packages or plans that individual can have if something is really major from a health condition happens. But 85 to 90% of the services are going to be run through a DPC, and you get to set that really strong conversation with them of understanding. Hey, I can refer you to specialist care. I have the imaging and labs that are priced through the practice. I can do medications outside of a office pharmacy as well, and you can come in and get those vaccines and flu shots and everything else that is available. And I think that's again the other value of what you're bringing to the marketplace from a DPC perspective. So let's talk about the four pillars. So the four pillars of one operating system, and this is how we see a structure. If you're looking to get into a DPC practice, and again, everybody's that is listening today is probably in a different journey amongst themselves, and everybody's at a different timeline. But let's just say that you started and you were thinking about this. What does that look like? You have to give yourself a 6-month lead to actually start that practice, or when you basically hang the shingle up and you unlock the front door and have patients coming in, because it's about a 6-month lead to get up, because we have to work on the technology and get everything ready for opening days. So you've got your socioeconomic deep dive analysis of the marketplace, the geography of the marketplace, and what we're looking at. You have to set pricing. We have to get documents in line for credentials and compliance within the state that you serve. You have to start to have those conversations internally with the powers that be, if that's a path you want to go down, or you have to, again, get your game plan ready to have that messaging across to your patient portal. You also have to set up your business. You have to find a location. And we always suggest that don't go crazy, because really at the start, you just need a modest office location where you have maybe one, maybe two, well, one, but maybe two patient rooms. You have an area for the physician to have an office. You have a front area, lobby area with a couple chairs, and obviously facilities to take care of patients while they're there. But it doesn't have to be extravagant, doesn't have to be big, and every market's obviously a little bit different in price on where that is. And what will also, it's interesting to find out is what other DPC practices are in that area, or how close are they, and what areas can you pull from? Because we're finding on average about between 20 and 25 miles that people will drive to a DPC practice. And that's areas outside of the existing areas that will also be additional business drivers for you as well. And then you get into really the operations of it. And this really consumes a lot of the physician time because you've got scheduling, you've got patient outreach, those types of things, and really understanding the vendors that you're going to be working with. And that's an assistant that we help support you as well. But there's vendor contracts and vendor contracts for your EMR and some of your other vendor supplies that you need to take care of. We're probably seeing that those contracts go back and forth in relations probably about a 3-month time frame. So again, if I said 6 months lead time, well, there's 3 just to get the vendor contracts in place. It takes about a month to get the socioeconomic breakdown. So that's 4. And now you're starting to build the actual website marketing. What does outreach look like? What does the community look like? How do I spread the word? And then understanding all the pro forma. What does a 3-year pro forma look like to you? Where's my break even point? How many patients do I need based on what my income level should be? How much can I bring over compared to how many more I need to fill the bucket? Those are all things that come into play that again, it's services that we provide. And then again, it's growth, it's outreach. And we always enjoy the physicians that are very open to meeting folks in the community, very open to the fact that they're part of a DPC and embracing and loving the fact of why they went this direction and really being able to cultivate. Because when we do outreach on behalf of DPC practices, we want them to engage with you. So we're driving these conversations so that they end up coming in and having those conversations because they want to meet the new physician. If it's not somebody they're familiar with, they want to get to know you. They want to understand where you came from. They want to understand the passion behind it and why you went this direction. So if you're a person that's able to do that, I think it just helps your practice even more. And I think it makes it much more valuable and embracing into the community. And sometimes it's tough for those to, depending on personalities, to kind of break out of that box a little bit. But the aspects and the benefits of being able to do that far outweigh it. So as I mentioned, it is a 16-week structured launch, really for every tier of those 4 I talked about. So again, just kind of reiterating your foundations, it's your business plan, your banking, your compliance, your malpractice, EMR selection. That takes time. Then you've got your website, your payment processing, your labs, credentialing, getting your workflows all set up, getting the whole infrastructure. Do you want someone to support you from the back end and the front end? Are you a hands-on physician that says, hey, I want to run everything, I want to do everything myself? Or I'd like to have a little bit of hand in that and a little bit of hand outside of that. Or are you an individual that says, hey, I just want somebody to help drive this for me, and I just want to see patients. I just want to enjoy the aspect of seeing patients. And so everybody has a little bit of that in them, and we help cater a program that is best fit for each of the physicians, how they're wired and what their mindset is. And then, obviously part of that is getting into the third aspect of patient enrollment, marketing, referrals, and then day 1 operations, checklist, verified practice, operating systems. Where do we go from here? And one thing I will tell you, that just the relationships that we've had with the 150, 60 some odd DPCs that we've helped launch over the last 10 years or so across the country, that once you get up and running and launched and you're through with our commitment to you and our contracting per se, we're always here for you. We're always here to help support you in any way. We're always here to give you insight, give you any additional tools that we've learned over the course of time, send information over your way that is helpful, and just be more of a thought leader from that perspective. But we never leave your side from the standpoint of being able to support you, because we believe in this foundation and we believe in this program, and we've seen a lot of success, and we just really believe that this is the future of healthcare. And I think from what you've seen and what you've read, I think you probably might feel the same way. So this just kind of restates what we've done. We don't own your practice. We don't want to own your practice. We want you to do it. We would love to be a part of the operations, the growth, and the intelligence and the administration of it, if you so choose. We'll handle all the scheduling, the prior auths, the follow-ups, the marketing, all those types of things. But we want you to drive the clinical care, and that's why you're a physician to begin with, and that's why you're thinking or going down this path of a DPC. We want you to own the relationship, and we want you to practice the way you've always wanted to run your practice or your business. And one thing that I always tell people is that I've never been a physician, but I've been in business in healthcare, and so it's a good happy mix, because physicians, obviously, depending on their background, may or may not have been in business before, because they've spent all their time and effort learning and practicing medicine. So you mix the two together and you're going to find success. And I think that's the best mix for success and long-term sustainability and growth. So that is the conclusion of today's Lunch and Learn, brought to you by Freedom Healthworks. I want to be cognizant of everybody's time, because that's why we did it at lunch, so we can get in, get out. If you have questions, we'd love to address them. We didn't want to take anybody else's time on this. So if you'd like to capture my email, please send me your name and contact information. What questions you do have, we're more than happy to respond to you via email. Or if you want to set up a call, we can do that too. Whatever works best. We're very easygoing, very work around everybody's schedule. So however best it works for you, we'd love to address any additional questions that you might have. And we hope everyone has a great day, and we do appreciate everybody joining us today. And thank you very much. Take care.